Thank you, Dr. Farooq Shah, Dr. Rajendra Chaudhary, sir, Tuli ma'am for joining, and Dr. Neeta is also here. So, ma'am, can you please take up?
Good evening, everybody. On behalf of the Postgraduate Institute of Child Health Noida, I thank everyone for joining in today. So these are a series of webinars which is being done in association with Thalassemia International Federation and Thalassemics India. And we thank all of you who have joined in today from various parts of the country. So every session, we take up topics which are related to thalassemia, from the epidemiology to the diagnostics to the difficulties, and so the programs are planned in such a way it's on a Saturday every month, and then it goes over common topics related to thalassemia, which are pertaining to regular management, and then we discuss the practical aspects of it at the end of it. So we are today, to set the ball rolling, we have Dr. Androlo Eleftherio, who has just joined in. She is the Executive Director of Thalassemia International Federation, and we would request her for her opening remarks. And first of all, Dr. Androla, a hearty congratulations to you for launching the 5th edition of the Guidelines on Management of Thalassemia. Over to you. You're muted, Dr. Androla.
Am I okay now?
Yes.
So thank you very much for the guidelines. And it is indeed a privilege for us to provide this service for the healthcare professionals across the world for the benefit of our patients. And we are very grateful to the academia research and to each one of you, because each one has its own level of contribution to these guidelines and to the spread of knowledge and education. So thank you very much, and allow me first to congratulate the coordinator and organizer, Dr. Nidara. Thank you so much for this initiative and for the privilege to represent Thalassemia International Federation. I would like to say a big thank you and gratefulness to Thalassemics India and my friend, Mrs. Chuli, who is always present with an impact in the course of her presence to everything, and has been a remarkable contributor to the work of TIP, to the Postgraduate Institute of Child of Health, and of course to the projects of India. But allow me also to thank and express the sincere appreciation on behalf of Thalassemia International Federation of the distinguished speakers who will contribute and give us their light and experience and knowledge on this very important subject relevant to the management of thalassemia, and part of the cornerstone of the management, which is related to transfusion therapy, creating alloimmunization in thalassemia, challenges to the journey, to the patient journey, to the journey of the patients themselves, but also to the healthcare professionals, to the treating physicians on how to address this. So many thanks to Dr. Rajendra Chaudhary, to Dr. Sadira Arora for the contribution that we are very interested to learn from. But allow me now to introduce my friend, Dr. Farooq Shah. What can I say about Farooq Shah? Well, I don't have anything written because I know her contribution, some of her contribution, out of my heart. She has been a key member of TIF's medical advisory panel for many years now, many decades, with undivided commitment to provide her knowledge and experience to the work of Thalassemia International Federation. But further than that, we know that she's a scientist, a medical professional, an excellent educator, and an amazing collaborator and friend to colleagues and patients and families themselves. She is a consultant hematologist. She has served at UCH, but for many years in Whittington Hospital. And she has a significant contribution in the international literature, of course, and amongst others, a key author in many publications, including TIF's educational material and very much including the guidelines in the very relevant chapter of transfusion therapy. Farag Shah has been, of course, a key speaker in TIF's international, regional, and national events. And she has undertaken consultanship in many parts of the world towards developing or strengthening services for the patients with hemoglobin disorders. And she has also served for some time as the director of the blood transfusion services of the United Kingdom. So I have no words, but only to congratulate and thank Farag Shah for her contribution in the history of the progress of the management for patients, for individuals with hemoglobin disorders. And I'm very interested, as always, to learn from her presentation. With these words, I would like to open this initiative and this workshop and wish productive outcomes. Thank you very much for giving us this opportunity.
Thank you, Dr. Eleftheriou, for those kind words and for introducing our first speaker. I would like to request Mrs. Tuli for the context setting because you know how important these sessions are for the Indian fraternity, because whenever we see guidelines which are published in the West, some of it we adopt it directly, some of it we need to have local modifications. So I would request Mrs. Tuli to share her experience before we go for the next, to the first talk.
So
Absolutely.
Good evening to all of you, and a very special welcome to the international guest speakers, especially the chairperson of today's session, Dr. Enrula Eleftheriou. Dr. Neeta has already spoken about Dr. Eleftheriou's contribution in TIF, but I would like to once again say that I have known both the international guests here from many, many years. So I will put it for both of them, a very warm-hearted and noble and elegant personalities I have ever known. I have met many doctors, but there are few special authorities and the doctors who really touch your hearts. I still remember the day when I met Dr. Enrula for the first time in Malta, and I met Dr. Farag Shah in one of the conferences when she had come there with a small baby in the trolley. And that was our first introduction when we came to know about each other. So after that, on so many occasions and all that, and every Dr. Enrula has said that her contribution in the field of thalassemia is known to all worldwide. But here, as far as India is concerned, we know that we have our different problems, and because of the huge number of the thalassemia patients, as well as the diversity of our country, and in some of the states we receive best of the treatment which is being provided either by the hospitals in the private or even in the government, or being supported by NHM, which is the Health Authority of Ministry of Health and Family Welfare. But still there are huge gaps because of the various reasons. I don't want to mention here and talk about that because that is a different subject. All I want to stress upon once again is that this is one series of the programs which are really complement. I remember Dr. Neeta Radhakrishnan when we spoke about that, and I have to thank their organization. I have to thank ECO also, and of course TIF for giving support for the organization of this webinar series. And Dr. Neeta Radhakrishnan has tried to draft it along with Dr. Satyam Arora and myself. We made sure that let's draft it in a way that it interests our medical authorities as well as the patients and the affected families also. So far we have touched, this is a fourth session, and so far we have touched on the different subjects about which Dr. Neeta Radhakrishnan has already spoken. So I don't want to take much more of the time, but of course, I would like to welcome and thank the chairpersons as well, Dr. Rajendra Chaudhary, who is here from Lucknow, and a very, very well-known person. I have a lot of knowledge about that. And my colleagues, of course, Satyam Arora and Dr. Neeta Radhakrishnan. Over to Dr. Neeta, please. Thank you.
Thank you, ma'am. I would like to formally welcome our other chairperson, Dr. Chaudhary. Dr. Rajendra Chaudhary has been the former professor and head of department of transfusion medicine at the Sanjay Gandhi Postgraduate Institute of Medical Science at Lucknow. And he is a chairperson of the Technical Resource Group of a National AIDS Control Organization at New Delhi. And he is the expert for transfusion medicine for National Medical Council in our country. He is the coordinator of the Specialty of Board of Medical Council of India for Transfusion Medicine and is a recipient of various awards. He supervised more than 20 MD theses for transfusion medicine, and his areas of interest are immunohematology, platelet serology, and clinical transfusion medicine. So from our side, we welcome you, sir, to today's session. And we would request you to kindly introduce the topic of alloimmunization so that the first speaker will start after that.
Thank you, Dr. Neeta, for kind words. All of you are aware that alloimmunization in thalassemia is a big challenge for transfusion support as well as for the clinical management of this patient. Fortunately, in India, the incidence of alloimmunization is in the range of 5%, so it's not very high. If you look at the figures in the Caribbean region or in Italy or in other countries, the incidence is about more than 20%. But in India, surprisingly, though we are a very diverse country, the incidence is in the range of 5%. So it is not difficult to manage transfusion support in this patient. However, in some cases, you get difficult antibodies, and then it becomes a real nightmare for transfusion medicine specialists to provide compatible blood to these patients. So it's not only the alloimmunization, there is another problem of autoimmunization. Some of the patients, they also develop autoantibodies against red cell antigens. And so then the problem becomes even more severe because you have to provide compatible blood for alloimmunized patient as well as autoimmunization. So I congratulate Dr. Neeta and Satyam for taking this initiative, very beautiful initiative. And also would like to congratulate the TIF and Dr. Shobha Tuli ma'am for taking this initiative. And I am sure this will help thalassaemic patients in our country. Thank you.
Thank you, sir. Now I would request our first speaker for today, Dr. Farooq Shah, to give her deliberation on alloimmunization in thalassemia patients, clinical presentation and management. Over to you, Dr. Shah.
Good afternoon, good evening, everyone. I'm terribly honored by all the flattering words from Andrula and Mrs. Tooley. It's very kind of you. I'm really honored to be able to talk about alloimmunization in thalassemia patients, and I'll do my best to make the lecture sort of easy to follow because transfusion medicine can become incredibly confusing. And I do end my talk with saying, please talk to the transfusionists because they are the real experts. So these are my disclosures, and today I'm going to cover transfusion in thalassemia, why we need to transfuse patients in thalassemia. And then I'm going to focus around some cases that I've managed who have either got alloimmune or autoimmune hemolysis or mixed, and then talk a bit about frequency and presentation, the diagnostics that you can use and what your management options will be. So everybody here is obviously very familiar with transfusion in thalassemia. The primary purpose of this is actually to ensure that the patients have a good quality of life. And the best way to do that is to negate the effects of chronic hypoxia, ensure that we're not causing bone marrow hyperplasia due to the anemia, allow patients to lead a normal physical activity from a life perspective, and to avoid the development of splenomegaly and hypersplenism. Reduction of iron absorption is also important, but that's a small amount in comparison to all of the other issues that patients have. So the challenge with thalassemia is making sure that you're transfusing the right patient, because the first premise with medicine is to, first of all, do no harm. And we don't want to be unnecessarily transfusing patients who do not require transfusion. So non-transfusion dependent patients generally are diagnosed above the age of 2. They generally have a mild to moderate anemia. They tend to have a higher hemoglobin F, and they generally do not tend to have major degrees of splenomegaly. The TDT patients, however, have got very significant anemia and are symptomatic from that anemia. They will quite often develop splenomegaly to a significant degree if we don't intervene early with regular transfusions. So in this population of patients, we need to be thinking about transfusion. Bear with me. Okay, so the TIF guidelines, which have just come out, are very clear around the indications for transfusion, and it is on the confirmation of severe anemia. And the laboratory diagnosis for this is a hemoglobin of below 70 on 2 occasions, 2 weeks apart, in asymptomatic patients. These are patients who are otherwise asymptomatic. And these patients need to have a thalassemia major genotype, so beta-0, beta-0 mutation or a beta-0, beta-plus mutation, or any other mutation that's known to cause transfusion dependency in thalassemia. Now, I appreciate fully that you may not have the genotype available for the patient at the time of the initiation of transfusion, and hence, in countries where we are getting prenatal, antenatal testing, and we are able to identify the genotype, we should be using the genotype to help support the decision. Laboratory criteria in patients where the hemoglobin is above 70 are important, because I have seen patients who are not transfused because the hemoglobin is running at 80, but they also have other problems and they should be transfused. And these are things like facial changes, poor growth and development, impairment of activity, the presence of fractures, or the presence of significant hepato or splenomegaly in patients who are about to start transfusion. It's very important that we don't get fixated on numbers, and we also focus on how the patient is doing clinically. E-beta thalassemia is a really important thalassemia disorder with a really wide variability in transfusion requirement and clinical phenotype. And you have patients who are very mild phenotype and patients who are very severe phenotype. And the hemoglobin isn't always concordant. So you may have patients with a hemoglobin of between 60 and 70 who are completely well with no evidence of extramedullary hematopoiesis or any other complications. And another patient with hemoglobin E-beta thalassemia may be severely symptomatic and actually need blood transfusion. So in these patients, having an individualized approach to the initiation of transfusion based on symptoms related to the anemia or the presence of extramedullary hematopoiesis is very important. Once you start transfusions for chronic symptoms, then you should be treating them exactly like you would a transfusion-dependent patient with similar schedules and similar management strategies. So when should you be thinking about transfusion? Well, this is a really simple growth chart, and you can clearly see that there is a failure to thrive happening in this young baby at around about 8 months of age. And this baby is going to need regular transfusion. So monitoring growth and development is very important when you're looking at newborn children with a diagnosis of thalassemia. Transfusion in patients isn't always as clear-cut as I've just shown on that growth chart. You do have children with thalassemia who are not transfusion dependent in a young age, but actually as they approach their pubertal growth spurt, they start to fail to grow and they do not then meet the growth spurt that they're supposed to have. And these children really do benefit from blood transfusions, and this is where we should be thinking about how patients are doing clinically. This is one of my patients with E-beta thalassemia. And you can see here that this patient is doing very badly. They're well below the centiles. They don't have any evidence of extramedullary hematopoiesis, but they're not moving into puberty and they're not going into their pubertal growth spurt. This is mothers and fathers' heights along with the mid-parental height. And immediately after we start transfusions, this patient's growth really kicks off, and this patient then completes puberty independently, and actually she is well into mid-parental height. So transfusion, there are some really clear indications such as failure to thrive, failure to go through growth and development at time points when growth and development is very important, such as puberty. However, transfusion decisions can be very difficult because doctors have different thresholds for initiating transfusion. Different patients have different thresholds for wanting or accepting transfusions. And this is where families and family education becomes extremely important. And also because the availability, cost, and the safety of blood transfusion is not the same in all countries. And there are conditions where blood transfusion may be associated with more risk from infection and various other complications in comparison to just managing in a non-transfusion dependent setting. And then there are patients who are very, very difficult to unpick what you should actually be doing. And this is one of my patients with a hemoglobin of 110. However, this patient has a very high reticulocyte count of 14% with about 300, 600 nucleated red cells per 100 white cells. And she's complaining of constant fatigue and has persistent dental problems. She also went through menarche at the age of 16 spontaneously, but then developed secondary amenorrhea at the age of 22, probably driven by a variety of metabolic factors. She's unable to gain weight and has been about 45 kilos for many, many years and did have a splenectomy. And despite this, she continues to struggle even with this hemoglobin. And she has got iron overload. Now, this patient, you can see from the blood results, is clearly going through a very stressed erythropoietic response. Despite having a good hemoglobin post-splenectomy, the presence of lots of nucleated red cells and a high reticulocyte count should be acting as a red flag for us to say that this patient is not coping with her underlying thalassemia, despite that decent hemoglobin. And this is another patient of mine who started blood transfusions at the age of 4 and became transfusion independent on hydroxycarbamide at the age of 19. These images are taken when this patient is about 35 years of age. And what you can see is that even with a hemoglobin of 85, she has massive extramedullary hematopoiesis with a hematopoietic mass that's actually pressing on her trachea. And the reason this scan was actually done was that she presented with a persistent cough, which was not improving. Putting her onto blood transfusions has actually completely resolved her persistent cough. So what do the guidelines recommend? They recommend that we give a blood which is matched for the ABO and the RHD, but also they recommend that we match for the rest of the RH group and KEL antigens. And blood should be transfused, which is appropriately matched to reduce the risk of alloimmunization. Blood should also be leukodepleted because it's safer, CMV compatible, and we should be using packed cells. In the UK, we've had a change in our recommendation, and rather than saying that blood should be fresh as possible, we've actually moved towards saying that blood should be as optimally matched as possible, and we prioritize better red cell matching over the age of the unit of the red blood cell. And the aim of this is to reduce the risk of alloimmunization in patients. As Dr. Rajendra said, the rate of alloimmunization is very variable in the literature, and there are many things that contribute to this, including age at first transfusion, the heterogeneity of the patient and the donor population. And in the UK, we've got a heterogeneous mismatch between donor population and recipient population. The extent of antigen matching definitely affects the risk of alloimmunization. I'll be talking about a couple of cases where this has actually happened, and the splenectomy status is important. And as Dr. Rajendra said, alloimmunization may be accompanied by autoimmune hemolysis as well. And the use of appropriate matching reduces the risk of this, but this isn't always easy. And in different countries, it may be more important to match for different antigens. So for example, in Hong Kong, you would need to match for the MER antigen in that population. Recent reports now, the reason I brought this up is that the TIF guidelines have been around for decades. Everybody knows that you need to match for RH and CAL. But recent reports, and this is a study from India, Egypt, sorry, the first one is a study from Egypt, looking at 14 TDT patients, 45% of whom were DAT positive. And I've highlighted here the amount of RH and CAL antibodies these patients had. We should be avoiding this completely unless the patient's got a D variant. They shouldn't be really developing anti-D. In Iran, another study, again published in 2015, shows alloimmunization rate is around 11%. But again, when you look at the antibodies the patients are getting, they're getting RH antibodies and they're getting CAL antibodies, which should be prevented if you're appropriately matching patients for these antigens. So this is a case of an alloimmunization. This patient's a beta thalassemia intermedia, and as you know, the age of transfusion is very important. This patient was not transfused at all until she became pregnant. She's RHD negative. She had very severe transfusion reactions through each of her 3 pregnancies and very nearly died on a couple of occasions. In 1994, she had a pregnancy associated with an intrauterine death and anti-DHDN. In 1995, this patient had a delayed hemolytic transfusion reaction, developed an anti-Big D and an anti-Big E, and clinically she behaved like someone who had hyperhemolysis. Her hemoglobin dropped to 35 grams per liter, and she was given steroids, plasmapheresis. Baby needed intrauterine transfusions, and she delivered a live healthy boy through a cesarean section. In 1999, another pregnancy, again associated with transfusions and severe hemolysis during the transfusions. She was treated with prednisolone for 6 months and actually received 30 units of blood postpartum because of the severity of her hemolytic response. In 2005, this is her youngest child, thankfully. She again had severe transfusion reactions when she required transfusion to manage severe anemia during pregnancy. And baby again had HDN with significant hemolysis. So when we first saw her, we did a full phenotype workup on her and a genotype workup on her. And phenotypically, she is big C, little c, and little e homozygous CAL negative. And back in the day when she first started those transfusions, she may potentially have been exposed to big E during those transfusions. So she's very difficult to transfuse now, and we won't transfuse her, even though she runs a hemoglobin between 70 and 65 most of the time. And if she does require transfusions in the future, we will treat her exactly like a patient with hyperhemolysis. Now, you would have thought that alloimmunization in the UK, with all of the stringent testing, monitoring, red cell genotyping, red cell phenotyping, the incidence of this would have gone down. But actually, this is serious hazards of transfusion data looking at 10 years worth of data in patients where serious hazards were reported. And you can see that alloimmunization, both hemolytic transfusion reactions and alloimmunization, continue to occur in about 5% of patients. And again, the question is, why are we still seeing these kind of problems happening? So as I said previously, the age at which you're transfused makes a big difference. And so a lot of the patients who are getting alloimmunization with TDT are patients who are being transfused at older age groups, not in the very young children. I'm Thalassemia Service, and this is a mini audit that I did in 2017 where we looked at all of our red cell antibody patients, and we had at that time 196 adult patients who were either intermittently or regularly transfused. 72 of these patients had atypical antibodies, with one patient who had a very strong autoantibody, and 6 patients actually needed washed cells for a variety of reasons. And 5 patients had actually got complex antibodies where NHS Blood and Transplant needed 7 days to source blood for those patients. So these are our patients who have allo antibodies that are significant. And here you can see that a lot of these are Rh, but we've also got KEL antibodies and JKA, as well as Lutheran and a few other antibodies. So these are mainly older patients who have been transfused abroad or were transfused at a time when we were not able to test for the full Rh blood groups, and we weren't matching blood at the optimal level. These are our patients who are getting wash cells. So not all of the patients who are getting wash cells actually have allo antibodies or autoantibodies. So the new guidelines from TIF, the UK Thalassemia Society guidelines, which were also published at the end of 2023, and the International Committee on Harmonization for Transfusion all make recommendations about what type of blood product you should be using for patients with TDT. Everyone is very clear about Rh and KEL matching, and all the guidelines concur for this. They also recommend compatibility testing prior to each transfusion episode and identification of appropriate new antibodies that a patient may have developed. The difference is in the ICTM recommendations, where they actually come out with a recommendation saying that if a patient has multiple allo antibodies, you should also be matching for Duffy A, Duffy B, JKA, JKB, big S, and little s in those patients. But this is actually based on low quality evidence and is a relatively weak recommendation. There's also guidelines, of course, on filtration. So alloimmunization diagnosis, patients may present with an unexpected drop in the hemoglobin before the next transfusion. Now, this may be very rapid, depending on if the exposure is to a previously made antibody, and the patient then mounts an antigen-antibody response rapidly, or it may be a delayed hemolytic transfusion reaction where the patient has not previously made an antibody to that particular antigen. Patients can present with delayed anemia a week or 2 after transfusion in an NTDT patient with new onset jaundice, the presence of fever, fatigue, or the presence of hemoglobinuria. And some patients may be asymptomatic, and some patients may only have mild fever and fatigue as their main symptoms. Some patients may actually come across with just a simple new antibody being identified, but are otherwise completely asymptomatic. And that's where we call the new antibody as a serological response rather than a hemolytic transfusion reaction. Now, alloimmunization diagnosis is very complicated in thalassemia, and the main reason for this is that the Coombs test, which is important in everybody else, may already be positive in a thalassemia patient. Bilirubin levels, which we look at for people who don't have thalassemia, are normally raised in thalassemia patients, but you will find that the bilirubin level goes up higher than the patient's normal baseline. LDH levels are again normally raised in thalassemia patients, but this may shoot up significantly. And again, the issue with reticulocytes, these are often raised in thal, but they may become more significantly raised following a hemolytic transfusion reaction. And the hemoglobin may drop below the normal level expected for the next transfusion, or the patient may actually present prior to the next transfusion with symptoms of worsening anemia. If you identify the presence of hemolysis, then on the presence of a DAT, then you need to go ahead and do elutions. And this is where the transfusion medicine specialists are so important in really doing a thorough workup of the antibody. And you should automatically be doing an antibody screen and considering genotype testing in your patient who's developing new antibodies. There's been some really interesting papers on recent testing comparing molecular versus serological. And the first study is actually from India, where multi-transfused patients with sickle cell disease and thalassemia got molecular genotyping using PCR and RFLP methods. And 80% of the molecular tests were at variance with the serological groups in this paper. And then a further study from America looking in sickle cell patients actually looked at discrepancies between serological and molecular results, and they found that 1.1% of patients had discrepancies between the antigen identified by serological testing and the antigen identified by molecular testing. So from a point of view of investigating someone in detail, you should, where possible, be aiming to go for genotypic testing to see what the actual red cell antigens are. Now, new technology has actually made genotype testing much, much cheaper. And in the UK, we're now genotype testing all our blood donors, and the cost is £13 per test. It's actually cheaper than doing serological testing in the blood donors. And this will actually allow us to match patients much more appropriately once all of the thalassemia and sickle cell patients are also genotype tested. So alloimmunization management is really straightforward. You need to transfuse with cells that do not contain the offending antigen. Supportive care, patient education, and good laboratory testing are absolutely keystones in ensuring that we manage these patients appropriately. I always say avoid hydrocortisone as pre-medication as a routine unless there's a very clear reason. It masks symptoms and it can cause a lot of problems in patients. So unless they're having proper allergic reactions, you should be avoiding hydrocortisone. If a patient who's got an alloantibody needs an urgent transfusion and it is life-saving and you can't match blood appropriately because you just don't have the blood available or testing is going to take too long, then you should pre-medicate the patient with IV methylprednisolone at a dose of between 250 milligrams and 1 gram and give IVIG cover for that transfusion event. And this is actually really important in patients who've got life-threatening anemia. I'm going to now quickly talk about autoimmune hemolytic anemia because I do think this is one of the hardest things to manage. This can be really life-threatening in patients who've also got coincidental alloantibodies because it becomes very difficult to match appropriate units. And serological evaluation will show that an antibody reacts against a wide variety of cells and quite often is pancellular. And autoimmune hemolysis typically is more likely to happen in people who started transfusion later in life or in patients who've already got alloantibodies from previous transfusions. And some patients may have a combination of allo and autoimmune anemia. What I think is really important is that we must remember that thalassemia patients can get other problems. So you need to rule out lymphoma, other hematological causes that may be causing the the autoimmune hemolysis. This is one of our patients with TDT. He had one episode as a child of autoimmune hemolytic anemia, which was treated with prednisolone and cyclosporin. He works full-time and he normally gets 4 units of blood every 4 weeks. He's got a pan-agglutinin and a positive DAT, which is long-standing. In October 2016, he came to the clinic with jaundice and started to drop his hemoglobin from his stable baseline of about 110 grams per litre. And we noted that he was getting an increasing transfusion requirement and we were struggling to maintain his hemoglobin above 100 and his bilirubin shot up. So this is what happened with his bilirubin levels. You can see a very significant jump at the start of the hemolysis, and then quite a fluctuating but significant increase compared to his normal baseline. His hemoglobin, this is pre-hemolysis hemoglobin. So you can see from here that that's 2015. He has had episodes of, significant anemia because he's been too busy at work, but his baseline hemoglobin tends to be about 100 to 110. So when he developed significant hemolysis, you can see here that his hemoglobin's running around 120. He then has a precipitous drop in his hemoglobin. We give him some blood transfusions. He catches up, but then goes back down again. And we're sitting at a hemoglobin of about 80 grams per liter without getting a good enough rise in his hemoglobin. And at this point, he's on almost every 2 weeks or 10 days from a transfusion perspective. So we give him IVIG and steroids and get him stabilized. And then he continues on high dose steroids with a very cautious reduction in the steroid dose once he's stabilized. And what you can see here is that his hemoglobin pre-transfusion, this is the baseline hemoglobin, continuously rises at a slow and steady rate. And we get to a point where we can actually stop the steroids. So this is his transfusion history. In 2015, he had 67 units of blood. In 2016, it was 90 units of blood. This is when the hemolysis started. And then in 2017, whilst he was weaning off of the steroids, the total transfusion load was 101 units of red cells. And by 2018, he was back down to his baseline of 63 units. So the management of autoimmune hemolytic anemia and thalassemia can be really challenging. And what I do want to say is that it's very important to be patient, because steroid weaning has to be done very slowly in these patients. IVIG, 1 milligram per kilogram per day on 2 days, and pulsed methylprednisolone is life-saving when you're starting off on the patient on the transfusion when they're very profoundly anemic and actively hemolyzing. Steroids maintenance, 1 milligram per kilogram per day, and I normally stay on this dose for at least 6 to 12 weeks before considering a reduction. You need to be brave with the steroids and just ensure that you've quietened down the hemolytic response as much as you can. Steroid weaning needs to be really slow. It should be in excess of 6 months for the majority of patients. And when there is a life-threatening severity of hemolysis, you should be considering either plasmapheresis, or what we do now in the UK is we go in with eculizumab for these patients to help dampen down the immune-mediated hemolytic response. So second line and third line therapy in patients. With my patient, particularly when he was bad, we were talking about going to rituximab, but braveness with steroids actually saved him rituximab. But we have used rituximab, obviously, in patients with severe autoimmune hemolytic anemia, and the dose is 375 milligrams weekly for 4 weeks, and it's very effective. The guidelines for general non-thalassemia patients recommend splenectomy. We would definitely not be thinking about splenectomy in thalassemia because the consequences of splenectomy are so severe. We would be thinking about azathioprine, MMF, sirolimus, considering combination regimes with steroids and an immunosuppressant drug if you can't wean steroids. And ultimately, you should be thinking about bone marrow transplant and curative therapy in patients where you simply cannot manage the hemolysis sufficiently. It's really important to remember that patients can have mixed allo and autoimmune hemolysis, and some patients even get cold hemagglutinins. You need to manage each component of hemolysis. You can't ignore one at the expense of the other. And my very recent experience in the last 3 months has been a case of avoidable harm in a 17-year-old female, non-transfusion dependent, who underwent a splenectomy in 2014. She was diagnosed with pulmonary hypertension a year later and therefore started on transfusions. She then, because of inappropriate matching, developed alloantibodies, unfortunately, for Rh and Cal, and she also developed an autoantibody. She is steroid responsive, but weaning doses down is very difficult, and we are going ahead with rituximab for this patient. And the icing on the cake about this splenectomized patient is that she did start on iron chelation in 2016 due to transfusional iron overload, and unfortunately has developed a gastrointestinal bleed and presented to the hospital with a hemoglobin of 30 grams per liter secondary to deferocyrox. And I can't help but think that if this young girl had not been splenectomized, we would not be in this situation. So in conclusion, transfusion is life-saving treatment, but there is a high risk of preventable harm with inappropriate or poor quality matching of red cell units. Genotype testing for donors and patients is becoming a reality, and there is data on reduced alloimmunization and better access to suitable units from the US. And this is looking at patients with sickle cell disease. And I just absolutely have to say that as thalassemia doctors, we are not transfusionists. Absolutely call the transfusion laboratory physician, get advice, because not all allo or autoantibodies are a problem or cause hemolysis, and variants may actually be a real problem. And talking to the experts will really provide reassurance and support about what actually is the right blood to give to the patient. And I just want to say thank you very much for asking me to speak. I'm very happy to answer questions.
Thank you, Dr. Shah. I think there are some questions in the chat box. If Dr. Chaudhary could take it up with, we can probably do it here and then go on to the next talk. So.
Okay, I'll open the chat box. Yes. Dr. Farooq, there is a question from Arvind. He's asking, please share RBC indices noted in your patients of autoimmune hemolytic anemia. What were the RBC indices in those patients having autoimmune hemolytic anemia?
Yeah, so as you know, Dr. Rajendra, that in the thalassemia patients, the red cell indices become very unreliable because the indices are generally reflecting transfused blood. However, the reticulocyte response is going to cause a small increase in the red cell indices, but I never rely on the red cell indices at all. I will rely on the reticulocyte, the bilirubin count, and other markers of hemolysis.
There is another question from Dr. Prasoon. Is there any contraindication for HbF inducers in the patient with pan-agglutination?
So the patient with the pan-agglutination, the purpose of HbF inducers is to ensure that the patient is making some hemoglobin F. And there is no contraindication to patients going on to hydroxyurea, even with a pan-agglutinin, and patients who are difficult to transfuse should certainly be offered hydroxyurea and other therapies that may improve their endogenous hematopoiesis. So I don't personally think that there is any kind of reason not to. My patient who had the anti-D, anti-E, and the terrible obstetric history has been on hydroxyurea for many, many years, and that is actually what's allowed her to function.
There is one more question from Dr. Mugdha. Why does a thalassemia patient develop autoimmunity?
That is actually a really good question. The autoimmunity with the blood cells is because of exposure to antigens. And if you do transfuse these children when they're very young, they are less likely to mount a T cell response and therefore become antigenic, if you like. My personal experience is that generally thalassemia patients don't develop autoimmune conditions, so they don't develop rheumatoid, SLE, these kind of problems. So I don't genuinely believe that they have a autoimmune predisposition. And I do wonder whether in the next generation of thalassemia patients, when we are genotype matching, which is going to happen in the UK, whether we'll actually see any red cell antibodies developing, because we may very well not see any future red cell alloimmunization if we're optimally matching our patients.
Somebody wants to know the clear indications for splenectomy in thalassemia.
So I will strongly recommend that you look at the TIF guidelines, which were published and made public last week. From my own perspective, is that splenectomy should be your absolute last resort. My only indication for splenectomy in a thalassemia patient is the presence of significant hypersplenism, so significant neutropenia and thrombocytopenia, which is difficult to manage. I will always hypertransfuse the patient first to see if shrinking the spleen down is actually going to avoid a splenectomy. Now, if you do splenectomize a patient, you cannot not transfuse the patient, okay? So this is a really important take-home. If you've splenectomized, you have to manage them with appropriate transfusion support, because red cell fragments, which were previously being removed by the spleen and are highly prothrombotic, they will continue in the circulation and your patient will develop pulmonary hypertension, which is essentially a almost fatal condition. So I would most definitely avoid. In the UK now, we have a national hemoglobinopathy panel. Any patient that needs a splenectomy is discussed at the regional multidisciplinary meeting and then discussed at the national panel if needed, so that the decision to transfuse is very carefully considered.
May I ask a couple of questions myself? Is there any role of hepatitis C infection in inducing autoimmunity? Because what I have seen in our patients, 12% of our multi-transfused thalassemics, they have autoantibodies, and all of them are positive for hepatitis C. And also this patient develop cryoglobulins. So is there any role of hepatitis C in inducing autoimmunity?
That's a really good question. And I have to say that our patients who have autoantibodies, they also were infected with hepatitis C. So the majority of them, not all of them, but the majority of them had co-infection with hepatitis C. So I concur with your observation, actually.
And the last question I want to ask is genotyping, because these thalassemic patients are transfused multiple times. So what sample should we take for genotyping? Because if you take the peripheral blood, it will be having the donor red cells. So what sample should we take for genotyping?
It does have donor cells, but we do genotyping on the buffy coat, on the white cells. So we always take an EDTA sample and we will do genotyping on the EDTA sample. And we've certainly not had any major, because all of the blood in the UK is leukodepleted and it's been stored in cold storage. We've not had any problems. So we've been able to do genotype testing without any problem in our patients. And I think that, with the new kits and with the new equipment, genotype testing is, very rapid throughput. The cost per test has gone down considerably and is definitely going to go further down. And I really, truly believe that this is the way we should be testing for the future.
Dr. Farooq? Yes, ma'am. Yes, Dr. Tuli.
No, please carry on. Please carry on.
Yeah. Thank you, Dr. Farooq, for excellent presentation. Madam, you want to say something?
I have few comments, Dr. Shah, and this is of course for Dr. Chaudhary and Satyam Kalra also. Well, we all heard that if the Whittington Hospital in 2017-18, I think Dr. Farooq Shah said that out of the 196 patients, 72 developed antibodies. So in our country, we all know that once the antibodies are developed, to get a unit of blood also, it becomes very, very difficult. And sometimes the patients have to wait for and the anemia develops. So I want to know from our Indian counterparts and the experts that we have seen this problem in our country, and I don't know that whether there is a solution to that or there is no solution to that, and it will really affect our patients' management and their care. And the second is, Dr. Shah said that autoimmune anemia becomes, if it is quite frequent, and once it is quite worrisome also, and the only option left at that point of time is BMT. So what I feel is that by the time the patients reach this stage and they have such problems, they are almost crossed the age when they can opt for BMT. So this is the two comments that I wanted to share with you, and maybe you have some replies, or maybe Dr. Shah can comment on to that.
Dr. Neeta, would you like to respond?
Yes, I agree, ma'am. So it is quite a tough thing to manage. And I was just looking at the treatment algorithm suggested by Dr. Shah. So initially it is all fine, but then once you are refractory, and some patients, once they respond and then you put them on phenotype matched blood, then they develop alloantibodies again and again. So it becomes extremely difficult to manage after a while. And then, like you said, they would have already passed that phase when a transplant can be done, without much risk. And it's a tough call at that point of time.
Thank you. Thank you, Dr. Neeta. And once again, thank you, Dr. Farooq Shah, for excellent presentation. Now, it's my pleasure to introduce to you the second presenter, Dr. Satyam Arora. Dr. Satyam is additional professor in the Department of Transfusion Medicine at Postgraduate Institute of Child Health in Noida, India. Dr. Satyam is the Regional Director of International Society for Blood Transfusion for Southeast Asia region. He is also Secretary for the Clinical Transfusion Group of ISBT and co-chair of Pediatric Transfusion Working Group. He is a member of various national bodies in India, and he has received many awards and many publications to his credit. I request Dr. Satyam, please start your presentation.
Thank you, sir. I hope my slides are visible.
Yes, yes.
Thank you, sir. And I would like to thank Dr. Farooq Shah because she's ended her presentation on a perfect note that the hematologist or the clinician should connect to a transfusion medicine specialist when they are suspecting an auto and allo antibody. And I think to help our clinicians, immunohematology evaluation is the key, is the test that we can offer. So in this presentation, I will briefly cover, few parts on transfusion requirements in thalassemia, alloimmunization in thalassemia. What are the possible immunohematology workups that we can offer? And then finally, I would, I've tried to compile and compare all the global recommendations and what is possibly will be a better way to follow in India for us. So again, thank you, Tiff, for providing an amazing resource to us, and it's freely available. It's released last week, and I had a chance to go through it. And there's an amazing table which talks about what are the various types of thalassemia, what is the various range of presentation of thalassemia. So a thalassemia patient can be a TTD, that is a major where it requires a lot of red cell support, and then there can be milder versions of getting into intermediate trait and a silent carrier. And this picture clearly defines that a degree of red cell support that they may need, and even during their clinical course they can shift from one type of presentation to another, and can influence the red cell need in these patients. So when we talk about transfusion, a regular transfusion is still the mainstay of the therapy. We know all our transfusion patients are mainly surviving, all our thalassemia patients are mainly surviving on transfusion. And when we talk about transfusion, there are four important aspects that we look at. One is the quality of the product. So the blood should be collected, tested, properly processed as per the regulations of that country, should be administered with the consent by the clinical team, and there should be a trained staff to manage if there is any issue during the transfusion, and all adverse events should be reported to the national hemovigilance program. And I'm happy to share that in our country we are trying to adopt all of these areas and trying to increase the awareness and education in all these areas. So when we talk about risk factors around transfusion, so one of the major one is TTI, that is the transfusion transmitted infection, followed by alloimmunization and then iron load. Although there are more issues which the child or the adult face, but these are the main three primary issues, and alloimmunization is something that we will be discussing in detail today. So alloimmunization to red cell antigens is caused by exposure to an exogenic red cell, that is a non-self antigen, either via transfusion or a pregnancy. This is a very important finding that only a fraction, that is 30% of all RBCs are identified because of the complex nature of these red cell alloantibodies during induction, and they have this evanescence kinetics in combination with other variables. So we can only, or we are only able to detect 30% of them, and many of them may pass on undetectably. Then there is a risk of clinically significant transfusion reaction, post transfusion morbidity, and increased cost of treatment with alloimmunization. Coming to broadly, what are the clinical consequences? So, in my past 10, 12 years of experience with helping thalassemia patients, we have tried to face all of these. There have been incidents of acute transfusion reactions, delayed transfusion reaction, bystander hemolysis, which are a higher risk with thalassemia intermediate patients. In the transplant setting, if you have an alloantibody, there is always a risk of delayed engraftment or an infusion reaction, or the reaction during the infusion. Then there are increased transfusion rates. So the red cell requirement increases, as the case shown by Dr. Farooq Shah. There is decreased survival of red cell. Then there is delay in sourcing of an appropriate match unit. A patient may have multiple alloantibodies against multiple antigens, and to get that unit, it usually takes 1 to 2 days or even more. And then economic burden. You need to have a lot of reagents, a lot of lab support. All that also becomes a major issue. So for aluminiization, there are some factors, that is, what is the size of donor pool that you're exposing your patient to? What is the ethnic differentiation? So this is another major factor why, as Dr. Chaudhary was mentioning, that in India, the incidence is around 5%, whereas in other countries, the incidence is higher, maybe because of the major differences in the ethnicity of donor and recipient because of global migration. Another thing is the lab support or lab resource, that are you able to identify or provide prophylactically matched red cells to your patients. If we look at red cell antigen part, so the antigens can broadly be classified as polypeptide antigen or carbohydrate antigens. And these are the polypeptide antigens which develop an IgG antibody which reacts at the body temperature and can be clinically significant. Another important thing with regard to the antigen is the dosage phenomena. So, depending on the homozygosity, whether the donor or a patient is homozygous for an antigen or are heterozygous for an antigen, the number of antigen on the red cell may vary, and that can also influence the incidence of these alloantibody. When we talk about antibodies, so IgG type of antibody reacting at the body temperature are the clinical significant antibodies which are troublesome to us. And for an alloantibody to develop in an individual, there must be an exposure to a non-self antigen and red cell binding motif capable of promoting this portion of non-self antigen exposure. And this is the reason why leukoreduction has been hypothesized to reduce the incidence of alloimmunization. Another important thing is the effervescence, where once we detect these antibodies and we provide antigen negative blood, over the time these antibody can become non-detectable. So documentation, tracking of record, or maybe having a repository or a registry of these antibodies for for every institute or every blood center to access can really go a long way in maintaining and avoiding an exposure to this antigen again. Broadly, I've just tried to classify what are the factors which may influence this antibody production. So if we see, donor factor, what is the degree of mismatch the donor has with the patient? What is the susceptibility of donor cells to destruction and lysis? That is the what is the osmotic fragility, donor demographic. Now vein to vein data from US have shown that there is a lot of significance on age and gender and ethnicity of your donor when compared to side effects in your patient, and whether there is an underlying disorder like G6PD deficiency in your donor. Coming to recipient, again, degree of match, HLA type. There is a lot of new data on few HLA mutation which can make a patient more prone for antibody development. Then immune status, whether the patient is immunocompromised, whether they are on drugs, whether they have some coexisting autoantibodies. Again, the demography of the patient, underlying disease, and thalassemia, sickle cell are more prone with respect to general population. Do they have any other associated disease inflammation or red cell burden or prior antigen exposure? Then coming to the red cell unit, how old is the unit, what is the storage duration, whether any modification like leukoreduction or radiation is done, what is the storage lesion, whether there is some microparticle or cellular contaminants with your red cell. And then coming to the antigen. So what is the immunogenicity of this antigen? What are the variants? What is the genetic heterogeneity? Are you providing a heterogeneous unit of the incompatible antigen or a homologous unit? And then density of antigens present on your red cell. So there are multiple factors which play an interplay for a patient to have or to develop for an alloantibody in a thalassemia patient. Now looking at global burden. So if you see on your left, there is a good table which defines, what is the incidence of alloimmunization in all type of diseases. And if you see acute leukemia, because they are immunocompromised, the incidence are very low as compared to general population, which is hovering around 5%. But when you see thalassemia, it is somewhere around 20% plus as compared to sickle, which has been reported to above 40%. So this is a brief, a snapshot of what is the prevalence of alloantibody in a multiply transfused patient population being reported. And very recently from Iran, a major data which came, which reported somewhere around 10%, and most common antibodies were against KID, D, and E. Again, anti-D is something that worries us, and very rightly was highlighted by Dr. Farooq as well. And in my further presentation, I will highlight that why anti-D is troublesome and what can we do better to reduce the incidence or to prevent the alloimmunization by anti-D. Now, this is a very good paper which came by a group from India, and Sir Dr. Rajendra Chaudhary actually led this paper and mentored it. This was a major meta-analysis of alloimmunization in India. And I think this paper should answer what Dr. Tuli was mentioning regarding alloimmunization in India, where 44 studies were compared of multiply transfused patients in India, covering more than 3 lakh patients. The alloimmunization rate was reported to be zero point 0.5 per 100 patient tested for alloantibody and 4.8 per 100 patient receiving a transfusion. And this paper actually recommended that we should consider matching for capital E and small c, as those were the most common antibodies. And this paper, this meta-analysis had a lot of different type of multiply transfused patient, but I have tried to highlight all the studies which talked about only thalassemia. So if you see, since last 2 decades, there have been many publications on alloimmunization in thalassemia, and if you summarize them or if you try to understand them as a whole, this paper actually talks about somewhere around 4.8% of alloimmunization. Again, if you see what is the type of antibody, again, anti-D dominates the type of antibody being developed, and anti-D development in a D negative patient is actually a disappointment for us, as that is completely a type of antibody which we can avoid. And again, I will discuss it a bit more in detail how we can avoid an anti-D type of antibody development. Again, if you see capital E and small c is something that this paper recommends, followed by KEL and M. Again, M is a very important example, as classically M has been thought of being an IgM, non-clinically significant. However, data from last 10 years have shown that M, if is IgG type reacting at 37 degree, is clinically important and should be matched for when you're providing a transfusion. So when we talk about what are the tests that we can support you with, is obviously this is the repertoire of our test from Immunomet Lab. We can do, ABO typing, D typing. So there's a reason why I have kept D typing separately. Again, phenotyping, majorly RH and KL. And when we want to go for an expanded antigen phenotyping, direct agglutinin test, which is, DAT, and it's a very important test. We can do either, a polyspecific DAT or a monospecific DAT, and that can help us differentiate the type of AIHA that we may be dealing with. Then indirect agglutination test is used for an antibody detection or screening and identification. And again, there are a lot of centers which use pooled O cell, although better is to use commercial reagent cell that can now even provide you an option of select cell in case you have multiple antibodies. Then adsorption elution study and saliva testing. So these are all the type of tests, which we can combine with each other, or maybe in permutation combination, we can try to help our clinician and thalassemia patient for providing some support. Before we go for any test, the pre-analytical factor becomes very important. So what type of sample should be correctly labeled and identified? Should be an EDTA sample, so a plasma gives us an option of working on both red cells and the plasma. Then it should not be of more than 3 days old, as been clearly mentioned by the BCSH guideline 2012. And even we need to archive this sample for 3 days in UK, and as per regulation 7 days in India, to work up for any post transfusion workup if there is a transfusion reaction being reported. Again, we do ABO typing, that is majorly to identify the blood group, that is the ABO blood group. Now this very important is, even all the guidelines and even TIFF focuses only on the patient blood grouping. However, weak D grouping in our donors is very important, and that is, I think, one of the ways or one of the reasons for anti-D development. So an appropriate weak D testing by for all D negative donors by IAT becomes very important, so that we are not exposing our patient to a weak D donor who can stimulate an anti-D production. And there is lack of data of weak D in various donor population across the world and even in India. So that becomes a major risk factor, and this is something that we can do just by proper degrouping. We can avoid the D antigen exposure to our patients. This is an antibody screen chart that can also be done for a using a pool cell or a commercial cell. This is a typical commercial cell, which is a 3-cell panel, and which can help us identify antibodies against these 18 antigens. If we have an antibody screen positive, we can go for an identification panel, which helps us to identify precisely that this antibody is against which antigen, or maybe to solve this puzzle of finding antibody against multiple antigen. Coming to another thing is the compatibility testing. This helps the major transfusion reaction, to avoid A to B transfusion. We can double check this ABO error. And there are two types of strategies. One is a type and cross match. The other one is type and screen. So type and screen is ABO and RH typing with antibody identification and detection, which is probably the strategy followed across the globe and in developed countries. And then there is type and cross match, where we do an ABO and RH typing and do a major cross match. Now, this is the major strategy which has been adopted in India, and that can be one of the ways and one of the areas where we can definitely work and increase antibody detection in India to, have our own data. Now, DCT was being discussed in the previous talk, and DAT is a very important tool to assess the in vitro sensitization of red cell. And one of the major and the largest study in India was on 319 patients on thalassemia patient, and I was fortunate to be part of that group, and where we found as the autoimmunization of as high as 28%. However, it is reported to be around 23% from Hong Kong, 23% from Albania, and around 6% from US. So this is another area of work where, these thalassemia patients, if they develop an autoantibody, it becomes difficult to provide blood units to them. Now, this is another paper which is by Dr. Rajendra Chaudhary and his group, which is very recently published, and they analyzed the prevalence of DAT positivity in thalassemia patient. So if you see carefully, they analyzed that DCT negative 159 patient with DCT positive 21 patients, and all of them are thalassemic patient. And if you see, there was a significant difference in the total bilirubin, in ferritin levels and IgG level. And as Sir was mentioning, 6 of them out of 21 were HCV positive. So we definitely need to work whether this is a reason, or this can be a reason for an autoantibody. If you also see, DAD positive patients were receiving significantly higher number of units, and they have a higher annual consumption of red cell as compared to thalassemia patients who were DCT negative. So this again highlights that the workup of DCT and workup of an autoimmune state in thalassemia patient, which should be carefully dealt with and worked up. Now, coming whenever we are talking about AIHA, it's they often present to us. These kids often present to us in emergency, and they require blood and they present with a very low hemoglobin, and it is very difficult to provide a unit to them if we don't have an RH&CAL phenotype beforehand to these patients, and this becomes a huge challenge. So, providing a least compatible or a best match unit have shown to be, a life-saving measure in case of an emergency, and should be considered for a unit which is showing a lesser strength of reaction as compared to rest of the units. And this transfusion can help the patient to stabilize and to tide over this emergency by the time the complete workup is possible. So adsorption elution studies are another studies where we have tried to solve multiple complex antibodies, help solve the alloantibody cases when they are interfering with autoantibody, and even having a select cell concept where you can adsorb one type of antibody and elude the other one. And all these technology were used very recently. We published an antibody against a low frequency antigen in thalassemia. A patient referred to us from Delhi, and we also had a case, an alloimmunization with autoimmunization in a massively hemolyzing thalassemia intermedia case, and that really gave us sleepless nights while managing these cases. Now, another important issue is, whether the patient is TDT or NTDT. And this was a paper which actually compared the risk of or incidence of alloimmunization in TTD versus NTD, and as well as in the lower or much milder variants of thalassemia. So if you see the first chart, significantly higher incidence of alloimmunization in NTDT as compared to TDT, and it is a recommendation that we should provide RH and KEL match units to NTDT also, as they may benefit more as compared to TDT. And often in our clinical practice, NTDT kind of lose that focus or lose that attention of providing a matched blood as compared to TDT. And if you see the chart on your right, NTDT has having a higher incidence as compared to the milder versions as well. So they are at the highest risk of alloimmunization. And now when we are talking about RH and KEL match, this is a very recent paper from US that actually talks about that what happens if you provide RH and KEL matched unit. So they studied these 40 chronically transfused patients who were ethnically different in US. They were from Asia, whites, blacks, Indians, and Middle East people, and they received 174 RH and KEL matched unit. Still on follow-up, 13 of these 40 patients develop alloantibodies. And even after RH and KEL matching, these patients developed 72% of antibodies were still against RH and KEL phenotype, against antigens. So this paper actually talks about some unique mutations which makes these patients more prone to develop these antibodies. So this, coming back to what Dr. Farooq Shah was discussing in her shots data, that even after providing RH and KEL match unit, they still have 5% incidence of alloimmunization being reported to shots. So this may be one of the reasons. We are managing phenotypically, but maybe there is some genetic mutation in these patients which makes them more immunologically prone to develop antibodies even when they are phenotypically matched between donor and the recipient. So when we are talking about, between donor and the recipient, there are a lot of patient factor that come into play. And there are some set of patients who actually don't respond and don't make any alloantibody. So they're kind of referred as non-responders, maybe because of there is insufficient exposure, there is some immune tolerance, they've been started transfusion early in their age, or they have some genetic HLA mutation which is making them more tolerant as compared to responders, who make antibodies very quickly, and they kind of make antibodies in multiple number. And even thalassemia intermedia comes into this group of responders who make antibody in higher number, in more concentration. And if you see the table on your left, I'm sorry, it's a bit small, where there is a lot of other factors, what kind of infections did this donor had, what kind of, whether they have some underlying malignancy, whether they were, they had splenectomy, whether they received leukoreduced blood or not, whether, what type of age of unit that they got. All these factors can influence development of antibodies. So, just responding to Dr. Tuli's question, that, maybe just RH and KEL phenotype matching may just not be an answer to prevent alloimmunization in this high risk group of patient. Now, as we come along, I've just tried to compare all the guidelines which are available. There is a classical, this BCSH guidelines, which was published by the UK NHS in 2012. Then very recently, the PHO chapter of IAP released a guideline in 2023, and where I was fortunate to be part of this group. Very recently, a week back, ICTMG released their updated guideline by the group of Simon Stanworth, and then TIFF released this week. So I'm just trying to compare what all these guidelines talk about on various immunomat tests, and do we have some consensus for us to follow in India. So if you see, ICTMG only talks about phenotype matching, so they don't talk about more of that. But if you see BCHS guideline and PHO guideline, they talk that it is mandated to do a forward reverse grouping. It is mandated to type D and focus on typing of D negative donors and confirming weak D status of these donors, by an IAT method or by an AHG cross match, just to prevent that we are not exposing our D negative patients to a D antigen or a weak D antigen. Similarly, TIFF only talks about forward reverse grouping, although not much about the D typing. Coming on antibody screening. So it should always be part of the compatibility testing as per the BCSH. It should be done on standardized panel cell. Pool shells should not be used, and identification should be done if your screening is positive. Similarly, is what IAP followed, that antibody screen should always be part of the compatibility testing, and if it is positive, one should detect the antibody. Similarly, TIFF also says that as a part of compatibility testing, antibody screen should always be done for thalassemia patients. And this is something that is lacking in India, and we still have to ensure that before all cross match, we are providing an antibody screen to these patients, as they are at high risk of developing an alloantibody, and we can pick and prevent that. We should use standardized panel cell. We should avoid using pool cells, as we can't really comment on the antigen profile. Now, coming to compatibility testing, what are these guidelines talking about compatibility testing and selection of these cells? So, compatibility testing should always be IAT based. It should include antibody screening. All the guidelines talk about that. And then ABO and D identical unit should be done as per the selection of cells. RH and KEL selection should be done for the first cross match, when, in case of the freshly diagnosed case. And if you have an alloantibody, you need to provide an antigen negative unit. So if you see, all these guidelines talk about that. And another addition that ICTMG talks about is that if there's a patient which develops an antibody, one should always try to provide an extended match blood, irrespective of, above the antigen negative that they have to provide. So if somebody have an anti-KEL or anti-C, you need to provide RH and KEL match to that patient above, providing a C negative unit. So documentation becomes a very important part for these patients. As I talked about, there is a tendency of, losing these antibody in the blood system, and that historical record should always be there in patient file, or a card should be provided to this patient. And we should have some idea of the workup. So this is a typical report that we provide from our patient, which developed an anti-CW antibody, where, we try to highlight that what is the detailed workup that was done. And when the patient comes back, or maybe report to some other blood center or some other transfusion medicine department, they know that what is the strength of dat and antibody positivity which was there previously when the patient reported, and what is the status on the follow-up. Finally, to conclude, immunohematology testing screening is of paramount importance in TTD management. Each thalassemia center should have a blood center supporting with an immunohematology lab, providing a detailed workup and for the support. RH and KEL matching for all thalassemia transfusion can reduce this risk of alloimmunization, and all compatibility testing for thalassemia should include an alloantibody screen so that we are able to pick these antibodies early, providing a lesser incidence of transfusion reaction, DHTR, and morbidity to our patients. So this is from my side. Thank you for your patient hearing, and I'll be happy to take some questions.
Thank you, Satyam, for a beautiful presentation on various laboratory tests that can be done in thalassemia patient. There are a couple of questions in the chat box. One is related to gamma irradiation. Does gamma irradiation of blood help in alumnized patients?
No, sir. The indication of gamma irradiation is to deactivate the WBCs that are there in the red cell, and that is to prevent the incidence of TAGVHD, that is the transfusion associated graft versus host disease. And there have been some papers which have shown that if you have a stored unit after gamma irradiation, because of red cell rupturing, it may cause alloimmunization. So it is definitely not to prevent alloimmunization.
Yes, and it is harmful to the red blood cells. Their survival will decrease after gamma irradiation, and that's not a good thing for thalassemia patient. If the red cell survival is decreased, their transfusion frequency will increase, and that will lead to another complication. The second question is from Dr. Prasoon. In India, out of the total collection of blood units, 2% blood units are going to hemolytic anemia patients. While on the contrary, we have so many thalassemic patients, but only 2% of the collected units are going to thalassemia patient. So, is it are we not treating our thalassemia patient adequately?
Sir, I'm not sure whether 2% of our total blood consumption is going to hemoglobinopathy. I think it's.
He meant adult. 2% of red cells are going to adults for treatment. So he's asking if we are losing majority of the TDTs early in life.
I mean, it is difficult to say. I think Dr. Shubha will be a better person to comment on it, because I feel now the overall survival and management of thalassemia has improved since last 10 days. I think ma'am will be the best person to respond on this, and we have more patients who are reaching adulthood if they are attached to a center and if they are getting adequate blood. Ma'am, your response.
Yeah, Dr. Satyam, I agree with you that I won't say most of our patients, but of course, some number of our patients have reached adulthood. As far as Delhi is concerned, I will share with you one example of the Indian Red Cross Blood Bank. They have a collection of 24,000 units of blood in a year. So out of that 24,000 units of blood, 15,000 units of blood are going to the thalassemia patients, and they have a registration of about 700 patients, thalassemia major patients. So you will notice that most of the blood is being given and distributed among the thalassemia patients. So I don't think so. I don't agree with this figure that maybe, that we need to look at that about the 2% which is being talked about.
Mm-hmm.
Another thing to that is, Dr. Satyam, that you have mentioned about the documentation, which is something very, very important. And another is that you have talked about that each transfusion should be, tested against RH and KEL. So this is something we have to really look at, that both the things in our Indian system.
Yes, ma'am. And I have tried to compare this across the globe. And I'm happy that PHO guideline, which both of us were part, it actually mentions, and it is the first guideline in India for thalassemia. It actually advocates that antibody screen should be part of all pre-compatibility testing in thalassemia. I think Dr. Andrula wants to mention. Yes.
Thank you so much. First of all, congratulations for an excellent presentation. We have learned so much. And what I would like to kindly ask everyone is that because India is doing so much for so many decades, focus on hemoglobin disorders, and I'm sure that there are very satisfactory patient outcomes. What we need to know from you is a national registry with some patient outcomes, like, for example, the mean age of patients, an age distribution of patients, percentage of morbidity and mortality, the number of annual deaths, because the age distribution of the patients will really answer the question of whether there is quality, adequate, and supplies of blood transfusion. It's an indirect measure, but it is a measure if you look at the national age distribution of the patients. And I'm sure that we need that because we are completing the global review of thalassemia, and we do lack some of these numbers so that we can advocate for what good services a country is doing for these patients. Unless you have a national kind of numbers, it is difficult to comment because there are excellent centers in India and there is a huge experience and medical education, but we need to see at the national level how it is, so that you can offer this excellent knowledge and expertise across the country. So a very humble request on behalf of TIF is to see whether you can accumulate such numbers and make a national registry and a national age distribution of our patients, of the TDD patients.
Sure, ma'am. I think Dr. Rajender is heading the TRG, the blood services of our country, and I think if sir takes up the lead, I think it's possible. Sir, please.
And this can be done. So definitely we'll try.
Thank you very much. Thank you. And
yeah. Satyam, regarding KEL typing, I had one question. In India, do we really need to type for KEL? Because 99% of the Indian population is negative for KEL antigen. So really, is it required? And secondly, in our systematic review, we found that the majority of the antibodies are against capital E and small c. So I don't think KEL matching is that important in Indian patients.
Yes, sir. I completely agree. And but just there is just one variation that we still don't know whether even with such a low prevalence of KEL antigen, we have presence of significant anti-KEL. So, and if the donor population of a blood center is, I mean, if we know the frequency of the antigens over there, and if we know the incidence is very low, we can avoid phenotyping. However, even with the low prevalence, the antigenicity is significantly there as it is causing antibody development.
Yeah. And the second question is related to the prevalence of alloimmunization in thalassemia. It is said that it's not very high. It is about 5%. So is it related to not having our own cell panel? Because we might be missing some antibodies which are specific to Indian patients. Like India, there are some India-specific antigens and they are not available on the red cell panels. So are we missing those antibodies and that's why the incidence is low?
Definitely, sir. One of the reasons that can be there, and we have recently identified Indian blood group antigen, which was reported from Ahmedabad a couple of years back, and it has been added to the international blood group registry. However, the clinical counterpart, I mean, they are also not reporting, reduction in frequency and increase of blood requirements. Definitely, a lot of non-specific DAT positivity can be something that we are not picking on our panel cells, and that can be a reason. Another issue, sir, which I feel is the donor phenotype homogeneity. So we have very less migration from other countries. However, if we see Middle East, if we see US, if we see Canada, if we see UK, countries which are reporting very high incidence, they have a huge immigrant population from various parts of the world. So their donor phenotype is very different from their patient phenotype. Their patient may be coming from an African descent and their donor is a white or is a European descent. So I feel in India, we don't have global migration coming into play at present. So we just have interstate migration, which I feel is still homologous to the antigen profile that we have. Yes, somebody coming from deep south to east may have a different antigen profile.
Back to Dr. Neeta to conclude the session.
So there are two more questions. I think one was asked quite early. I would request Dr. Shah to answer. There was a question how to differentiate between alloimmunization and autoimmune hemolytic anemia clinically.
You actually can't, I'm afraid, because hemolysis clinically is just going to show as hemolysis. The only way you'll be able to differentiate is by using your transfusion specialists and with the, elutions, adsorptions, and various other techniques, they'll be able to hopefully identify whether it is an allo or an auto antibody. But clinically, you can't.
Yeah. And one more question on why is there a higher chance for NTDT to develop alloimmunization? Is there an underlying cause? I think you've already alluded to it, but maybe the person missed your part of the talk.
Yeah, so when you transfuse children very, very young, below the age of 1, they don't mount such a good immune response because they just simply don't have enough T cells floating around to be able to become immunogenic. But if you're transfusing them older, then the system has matured. You're more likely to do that. But the other thing that Dr. Satya just raised is the fact that NTDT patients are often not given RH cell-matched blood because people don't know that they're NTDT. The transfusion lab hasn't been told that they're non-transfusion dependent thalassemia. They may get transfused at another center to their normal center. And because the transfusion record is not shared, patients will get exposed to red cell antigens that they should not be exposed to. And certainly that is a real problem for NTDT patients who generally don't access hospital very often.
It's very important what Dr. Shah has just raised and the importance of sharing health records, patient health records. Yeah.
So what we've done in the UK is we've managed to get all of the blood transfusion data from hospital laboratories and from NHS blood and transplant onto the National Hemoglobinopathy Registry. It was literally the last thing I did before I left. And so that data is now available to all users of the National Registry, and transfusion biomedical scientists can log in and actually see the red cell antigens, the red cell antibodies that a patient has, even if that patient is not their normal patient.
Yeah, excellent.
Yeah, Dr. Prasoon has just informed that Indian Council of Medical Research has the registry on thalassemia, and they have about 4,000 patients registered.
Excellent.
So that registry is taking in data. It's not longitudinally following it up, but there is a start. So we are all contributing to the ICMR registry, and hopefully over the years the data would become mature, and then we can give better data follow up.
Good evening, madam. Just in Tamil Nadu, we have a very good registry system by the government of Tamil Nadu. Even the practitioners who are there, we have to refer to that, and the government is taking care of, and all transfusion, other things are they are doing it freely. So the Thalassemia Society in Tamil Nadu with the government is going very well. It is just for information, madam. Thank you.
Thank you, sir. I think we've reached the end of our session today, and I would request Mrs. Tuli to kindly wind up the session and thank all our speakers and chairpersons.
Thanks, Dr. Neeta, for bringing me in. Dr. Chaudhary, I have one submission, and we have heard from Dr. Nrula Al-Fitri also that how important it is, and then another comment from the Tamil Nadu when the work is going on. So my humble submission is that this registry is very, very important. This will let us know that how our patients are progressing, how many of them are reaching the adulthood, how many we are losing it. And I have talked about this in the Ministry of Health, Family Welfare also. I have talked at this within the blood chapters also in Delhi also. But I feel that there is somebody has to take the call, and we are all there to support it. please, if you can start it and roll it on, that we are able to see a build-up registry for our patients, And here, before I give the formal vote of thanks, I just want to add on to that. I remember when we were talking about, when Dr. Nrula was talking about, and when Dr. Farooq Shah was talking about, I remember what role, this is for the participants' information, that in India in 1980s, there was nothing. And the approach about thalassemia was very, very negative. And I cannot forget, and I want to acknowledge once again on this platform, and I will keep on doing so from time to time, that the role that the doctors of Whittington Hospital, from where Dr. Shah was working, and earlier we had Dr. Beatrix Wonky there, and we have, of course, at the moment, Dr. Walker also. And the role what TIFF, I remember it, we had so many visits of the doctors to our country when the knowledge was absolutely nothing. We were in dark. Our patients didn't have any kind of hopes. So it is only through the expert international doctors who took the lead to come to our country, and of course to bring them all together with the help of the thalassemia NGOs. And today, with the help of the knowledge and the material that we have today from the TIFF, whether it is from the Government of India, whether it is from the IAP, our patients have some literature to read through, go through the guidelines. And some of our patients have almost become doctors, not only in abroad, but in our country also. So I'm really touched that today we have the two people from TIFF and from Whittington Hospital who really played a key role in bringing transformation in our country as far as the patient's care and the family's care is concerned. And I'm very thankful at the same time with the work that our Indian doctors are doing at the moment towards caring and the management, whether it is the hospital, whether it is the blood banks. This is all from the patients community that I wanted to share here. Now, the formal vote of thanks, of course, first of all, to our chairpersons, Dr. Rajinder Chaudhary and Dr. Nrula Alfitrio, and to both the speakers, Dr. Farooq Shah and Dr. Satyam Kalra, and to the moderator and my colleague at ECO program, Dr. Neeta Radhakrishnan, and of course to the host ECO authorities, and to all the participants who took their time to listen to us. And Dr. Neeta, I don't want to end up like I shared the messages that I shared with you through WhatsApp. This is something very, very important topic. We have to look at that how we can incorporate more sessions like this and more patients and families and the doctors, maybe through a panel discussion. We need to go through, and what we have learned from the whole idea behind this webinar is to get the best practices from abroad and try to incorporate them, that we have been doing it for many, many years and for the coming years and for the future, because this is all for our patients community. With these words, I once again thank all of you for your time and for being with us. Thank you very much.
Thank you. Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you. Bye.
Thank you, Tiff, for suggesting excellent speakers for our webinars so far. And we're really touched by the expertise that have, as in both national and international expertise that has come in. And I think I agree with Tuli ma'am that we should take it forward and develop this further so that it will benefit patients in our country. Thank you.
Thank you all. Wonderful session we had. Thank you.
Thank you.
Thank you, everyone. With this, I'm closing.
Thank you.